Ladies and gentlemen, please welcome American College of Sports Medicine President, Dr. Walt Thompson.
Thank you for that. Thank you for that music. I didn't choose that music, by the way. Someone else did. Good morning. It's my pleasure to welcome you to Minneapolis for the 65th annual meeting of the American College of Sports Medicine, the 9th World Congress on Exercise Medicine, and the World Congress on the Basic Science of Muscle Hypertrophy and Atrophy. Congratulations to the 2018 Program Committee chaired by Katie Schmitz, and organizing a superb mix of presentations and workshops that reflect the diversity of our membership and to highlight ACSM's unique role as an international leader in the scientific discovery and translation of exercise science and sports medicine. I'm pleased to announce that we have several showcase events happening Wednesday, Thursday, and Friday during the lunch break. These events can be found in your program books as well as on the mobile app. Please make room in your schedule today to attend today's midday session and hear from U.S. Surgeon General Dr. Jerome Adams, a great friend of the American College of Sports Medicine. Dr. Adams' motto is better health through better partnerships, which will be discussed during this session. Just a few days ago, Dr. Adams was asked by the President to attend an event at the White House just today. Fortunately, he is still able to be with us by live video, so don't miss this interactive session at 11:45 today. At Thursday's midday session, we have the pleasure and the distinct honor of having Olympic legend Jackie Joyner-Kersee with us for a panel discussion and questions and answers from you. Among other honors and awards, Jackie was named Sports Illustrated's greatest female athlete of the 20th century. Learn how she discovered the many benefits of exercise and physical fitness out of her track and field career. Midday on Friday, join Dr. Katie Schmitz as she has conversations with Gabriella Grunewald and Dr. Susan Helmrich, both cancer survivors, sharing their stories of competing with cancer. There will also be an industry-sponsored session midday on Friday, The Science of the Running Shoe, with sponsors discussing the diverse philosophical approaches to running shoe development and the science underlying how these shoes are made. I'm hoping that your schedule will allow you to attend all of these special additions to our conference. You will not be disappointed. Throughout the week, be sure to join the ACSM annual meeting conversation on social media by using the hashtag ACSM18. I'd like to remind everyone to review and follow the new photography, videotaping, and social media policy for our annual meeting. It can be found in your program. We appreciate your cooperation. Now let me introduce several individuals being recognized this year for their distinguished career and outstanding scientific scholarly contribution to sports medicine and/or exercise sciences. ACSM has selected 7 outstanding individuals to receive the 2018 Citation Award. They include Dr. Larry Armstrong, Dr. Dave Bassett, Dr. Mary Jane D'Souza, Dr. Bill Dexter, Dr. Sandy Hoffman, Dr. Tim Lightfoot, and Dr. Janet Wahlberg-Rankin. Our highest award, the ACSM Honor Award, is being bestowed upon Dr. Barb Ainsworth. The award winners will be announced will be in attendance throughout the week and will be formally recognized Friday evening during the awards banquet. As you see them in the hallways, please be sure to congratulate them for their outstanding achievements. Please join me in congratulating each of these esteemed award recipients. Finally, I am very excited to announce that the American College of Sports Medicine is embarking on a new and visionary capital campaign. As I transition out of the role of president this Saturday, I will turn my attention to serving as chair of this campaign, a position I was graciously offered and humbly accept. I do so because I passionately believe in the work of sports medicine and exercise science. And this campaign will be the catalyst for the future of our field. Ladies and gentlemen, I'm proud to present Elevate. You'll be hearing more about the Elevate Capital campaign in the days and weeks ahead. I want to take just a moment to introduce the Capital Campaign cabinet members that have agreed to serve with me in leading this effort. Katie Schmitz, Liz Joy, Bill Kraus, Jim Pavarnik, Sherry Blowett, Leah Robinson, Calvin Cole, Barry Franklin, Pam Peake, Mark Hutchinson, Angela Smith, Bill Roberts, Nicole Keith, Katrine Tudor-Locke, and Jim Whitehead. Thank you very much. While you're here at the annual meeting, please engage with the campaign by wearing the Elevate ribbon you were given when you picked up your packets. In fact, if you're wearing your ribbon now, please hold it up high. And be sure to visit the large Elevate display and writing wall near the entrance to Hall B. We'd like you to write on the display and share what you'd like to elevate, and then take some pictures and share them on social media by using the hashtag ElevateACSM. You can also pick up an Elevate information card. Thank you, and let's elevate together. See, I don't have somebody back here cue the applause. Now I have the honor of introducing our Wolffe Lecturer. The Wolffe Lecture is the keynote address at the annual meeting in memory of one of ACSM's founders and first president, Joseph B. Wolffe, MD. Dr. Ann McTiernan, MD, PhD, FACSM, has been invited to deliver this year's lecture entitled Physical Activity for Cancer Prevention and Treatment, State of the Evidence. Dr. McTiernan is a cancer prevention researcher at the Fred Hutchinson Cancer Research Center in Seattle, Washington. She's a faculty member in the Division of Public Health Sciences Program in Epidemiology of Washington Schools of Medicine and Public Health. Her research focuses on identifying ways to prevent new or recurrent cancer with physical activity, weight loss, and chemo prevention. She received her PhD in epidemiology in 1982 from the University of Washington and her MD from the New York Medical College in 1985. She completed residency in internal medicine from the University of Washington in 1992. Dr. McTiernan has published more than 400 scientific manuscripts in peer-reviewed medical journals. She was the lead author of the book Breast Fitness, an optimum exercise and health plan for reducing your risk of breast cancer. She was the editor of 2 academic volumes, Cancer Prevention and Management Through Exercise and Weight Control and Physical Activity, Dietary Caloric Restriction, and Cancer. Most recently, she published the memoir, Starved, A Nutrition Doctor's Journey from Empty to Full. Dr. McTiernan is a member of the 2018 U.S. Physical Activity Guidelines Advisory Committee. Her additional advisory committee work included the 2008 U.S. Physical Activity Guidelines Advisory Committee, the International Agency for Research on Cancer, the World Cancer Research Fund, the Susan G. Komen Scientific Advisory Council, the American Cancer Society, and the Patient-Centered Outcomes Research Institute. She has appeared in several media on the topics of physical activity, obesity, nutrition, career prevention, and general health topics. And just a side note, you may not know this, but we had some weather last night. Dr. McTiernan flight was canceled, and she took a very early flight to get here at 6:15 this morning. So please join me in welcoming our 2018 Wolffe Lecturer, Dr. Ann McTiernan.
Well, good morning, and thank you very much. I'm very appreciative to the ACSM for inviting me here, for letting me talk to you about cancer and exercise. Special thanks to Dr. Thompson and to Dr. Katie Schmitz for their leadership and allowing this area to be moving forward and to be highlighted today. So I want to ask a question first before I start. I would like anybody who has had any relative, loved one, friend, colleague, or themselves who have had cancer to raise their hand. I see hands everywhere. So cancer really touches everybody. It's extremely important, and this is another place where American College of Sports Medicine can have some great leadership, and already does, in promoting exercise as part of a healthy lifestyle for cancer prevention and for cancer survivors. So I'm going to talk about a few things today, a little bit of information about cancer, not much. I'm going to highlight information from the Physical Activity Guidelines Advisory Committee, because we had the most up-to-date information on physical activity and cancer. So that's what I'm using as my base of information today. I'll talk about cancer prevention and cancer survivorship, because we touched on both of those in the guidelines. I will also talk a little bit about mechanisms. How could cancer be related to exercise? And I'll give some information about my thoughts on future research implementation, and then some conclusions. So first, in statistics, 4 in 10 Americans will develop cancer in their lifetime. 1 in 5 will die of cancer if the current statistics hold true. In 2018, an estimated 1.7 million new cases of cancer will be diagnosed in this country, and 609,000 persons will die of their cancer. Because of the incidence of cancer, and also now because luckily more people are surviving long-term, there are 15.5 million cancer survivors in the United States. So a lot of people that are dealing with this, their family and friends are dealing with it, and these are people that will definitely could be using help and will be looking towards exercise specialists for help. Some of the more common cancers in the United States: in women, breast is most common invasive cancer, lung and colon, rectum also. And for men, the most common is prostate, but also lung and colon and rectum. There are over 100 types of cancer if you think of the type of place on the body where it could occur, but each cancer is also composed of many different subtypes, and now we know more that there are many genetic subtypes. So you can imagine the amount of types of cancers that can be treated differently. They can have different causes. And so when you start to look at what causes cancer, can exercise be related to cancer, it can be a very daunting task. But all cancers are characterized by abnormal cell growth. What are causes of cancer? This is a very simple pie chart, obviously. But only about 10% of cancers, even though cancer starts with a genetic mutation, only 10% are for a known hereditary cause, where you can identify a person has a gene, that gene caused their cancer. 90% are thought to be due to something in the environment. I'm not going to talk about other environmental causes, but exercise, physical activity, lack thereof, could play a part of that environmental cause of cancer. But the flip side is that exercise could be a preventive mechanism. In terms of brief history, it's a very young science. The risk of cancer has been looked at only since the 1960s, first looking at cancer mortality in people that exercise versus those who didn't. Occupational activity was looked at in the 80s, and then recreational and physical activity and total physical activity was looked at starting in the 90s. So these are the epidemiologic studies. Survival studies didn't start being looked at until the 2000s. And when I say these studies, I mean cohorts, so looking at a large group of patients or a large group of healthy people and following them forward over time. So kind of small print, and I apologize for that, but I want to talk, I just wanted to give you the details of the Physical Activity Guidelines Committee work. It's a collaboration of the US government, the Department of Health and Human Services, CDC, NIH, and the President's Council, and that was before Dr. Oz joined it. The Physical Activity Guidelines Advisory Committee is what I served on, and where I'm going to be giving some information of how we came up with our deliberations and what we decided. So there's 17 experts and consultants. I'm not naming them all. Many of them are here at the meeting, and you're going to be hearing other talks from them. It took us 2 years, 5 meetings, and we produced a report, which is online. You can find it online, and I've put the URL at the bottom there. We had 9 subcommittees, and I underlined 2. One was cancer and one is chronic disease, because those are the two committees where we looked at cancer. We had public commentary, and now the government is working on the guidelines, so I can't tell you what the guidelines are. I don't know what they're going to be, but I'm going to tell you what's in our report, what we had, our advisory committee came up with. So we had some questions about cancer, and this is what guided what our search was and what literature we reviewed. We wanted to know what is the relationship between physical activity and the incidence, the number of new cases of invasive cancer. Is there a dose response? If you exercise more, you have a better effect. Does it change by sex or race or ethnicity or by age? What about specific cancer subtypes? And I told you how many cancers there are, over 100 by body site, but many more by molecular changes. And what about persons at high risk of cancer, either for a genetic reason or for having a precursor to cancer? We also wanted to know what's the relationship between sedentary behavior and risk of cancer. It's a brand new field. And then we wanted to know, among cancer survivors, what is the relationship between a physically active lifestyle and survival from cancer, either overall survival, because many patients die of other diseases besides their cancer. So overall mortality, cancer-specific mortality, and then cancer recurrence. Now, we did not touch on quality of life or side effects, and that's something that others at ACSM, especially Dr. Schmitz and Melinda Irwin, other people are very involved in that area. We didn't touch on that. We didn't have the time to be able to do that. We did a systematic literature review, and I may name the bases, the databases there through 2016. We decided to look particularly at meta-analyses, pooled analyses, systematic reviews, and somewhat at source papers, but mostly we relied on these larger meta-analyses, and I'll tell you why in a minute. The studies could have been randomized controlled trials or observational studies, either prospective cohort study or a case control study. Prospective cohort study being where you identify people at one point in time, ask them about their physical activity habits, and then follow them up over time to see who develops a cancer and who doesn't. Similar thing for survivors. You identify a number of cancer survivors, cancer patients, ask them about their activity levels, and follow them forward for outcomes. In some cases, we allowed information from case control studies. I won't get into the reason why they're a little bit more likely to be biased, but there are some cancers for which case control studies were the only available data. And then if we wanted to look at the effect size, how much of a change in cancer risk would you see with activity? We really wanted an effect size, and we used the most recent meta-analyses to get that. So what's the benefit or risk of meta-analyses and pooled analyses? So meta-analyses combines together results from several different studies. Pooled analyses, on the other hand, uses data, source data from the studies. So a little better handle on the exact data and coming up with a more cohesive result. The advantages of these two types of studies is that the systematic review tends to, especially the meta-analysis, uses a systematic review of published and sometimes unpublished studies. They do quality assessment of the source documents. They harmonize the data to some degree, and they can give us effect size and statistical significance. Some disadvantages: the source populations might vary, the physical activity might be difficult to combine, and that's going to be, I'm going to show you that, that's going to be what we found for all of these studies. You might miss some very recent studies. And then the subgroup analyses, some of those sub-questions that I mentioned that we're interested in. What about different race ethnicities? What about different sexes? What about different cancers? Those are often very difficult to find within these meta-analyses and systematic reviews and pooled analyses. So what did we find? For the cancer prevention, we went through several hundreds of papers and decided that some were appropriate, and we reviewed then 45 systematic reviews and meta-analyses that it represented millions of individuals who were in these epidemiologic studies and thousands of cancer cases. Most of these were in the United States and Europe, a few in Asia. Some of them focused on one cancer, some on more than one. The physical activity was all collected through self-report. No objective measures in any of these cohort studies. And the questionnaires varied. So the types of activity that was queried in those various studies or that was assessed was mostly recreational, a little bit with occupational, almost none looked at household, some looked at total physical activity, and almost all the activity that they looked at was aerobic. Some of the meta-analyses were able to look at dose response, tend to use met hours per week for studies where they had that data available. Most decided a met value of 6 for vigorous activity. But one of the issues for all of these studies that we found over and over again was that the cut point for what's the highest level of activity versus the lowest level varied. It varied across all of the source papers, the cohort studies that the meta-analyses derived their studies from, and then it varied across these meta-analyses. For cancer survival, we included 16 systematic reviews, some on one cancer, some on multiple cancers, but breast cancer is the type that was included the most often. Again, the same information was collected, questionnaires varied, and there was some variability in the types of physical activity. None of these systematic reviews in cancer survivors included children, so a focus there was on adults. The Physical Activity Guidelines Committee decided that they really wanted to assign a grade of how good the evidence was. And I'm just showing you what we decided was strong evidence. So study populations, interventions, and outcomes are directly related to the question. There are a lot of studies. They're large enough to be able to come up with reasonable results. The strong study design is free of bias as possible. The size of the effect is practically meaningful. And And then the results could be generalizable to the US population. So this was easy, right? You can imagine. You can try doing this for any of your studies or any studies you're trying to review. It was very difficult. But nevertheless, we persisted and we did come up with what we considered grades, evidence grades. So I'm just summarizing what we found in terms of what is the effect of physical activity on incidence of cancer, and these are the different types of cancers that we looked at. And here it's for high versus low level of physical activity, so I can't tell you what the level was. The meta-analysis couldn't tell us that either, and even the pooled analysis. But you can see that for quite a few of the cancers, we did decide that the evidence was strong, that for breast, colon, endometrium, esophagus, adenocarcinoma, stomach, bladder, kidney, and lung, not lung, but stopping at kidney, we decided that the evidence was strong, that there was a risk reduction, a reduction in incidence of cancer for individuals who exercised at high versus low levels. And the range was about 15 to 20% reduction in risk. So then we wanted to know, is there a dose response? If you exercise more, do you have more effect than if you exercise a little bit less? And so as you can see, we decided that for some of the cancers, there was very good evidence. So for mostly for breast and colon, which is very similar to what we found for the 2008 physical activity guidelines work, but at that time we did not have the benefit of meta-analyses, so we couldn't come up with an estimate of effect size. But for breast and colon, we think there is a dose response. We did not see for any of the cancers, we didn't see evidence of a threshold. So you see benefit even if you get your clients to exercise a little bit, they still could have some benefit down the road. For many of them, however, the evidence was not clear for dose response. So it was either moderate or limited, or that we saw no effect of dose response. For some cancers, as I've listed at the bottom, lung cancer, we only found moderate evidence, and that's because we couldn't be sure that there was not residual confounding by cigarette smoking, meaning people who exercise are less likely to smoke, and smoke is a major cause of lung cancer. And several other cancer types that were less common types, there were some meta-analyses, but they just didn't have enough evidence for us to feel strongly about the results. Prostate cancer is a common cancer, but we still did not find evidence that that was a strong effect or a convincing effect in terms of exercise and risk of developing prostate cancer. So what about sedentary behaviors? Well, one of the committees of the Physical Activity Guidelines Advisory Committee focused on sedentary behavior, and they did review source papers. They didn't just rely on meta-analyses. And they found only moderate evidence was available at this time. This is one of the newest fields in epidemiology of movement and risk of many diseases, but especially for cancer. So they only found moderate evidence that there's a relationship between increased sedentary behaviors and higher risk of cancers. And the three they found that for was endometrial, colon, and lung cancers. And they found insufficient evidence to determine whether or not you could overcome the effect of that sedentary lifestyle by being physically active. What about cancer survivors? There were not that many cancers for which there was enough data in survivors to say much, but we were able to look at the more common cancers. Remember, as I mentioned earlier, the most common cancers in women in this country are breast, lung, and colorectal. And for men, there's prostate, colorectal, and lung cancer. But we did find the the best evidence are for breast, colorectal, and prostate cancers. In terms of all-cause mortality, and again, this is an important endpoint for cancer survivors. Most men with prostate cancer die of cardiovascular disease, not of their prostate cancer. And many women with breast cancer die of cardiovascular disease. So it's important for those patients to have things and advice, lifestyle interventions that can reduce the risk of all-cause mortality as well as cancer-specific. So we saw about a 48% reduction in breast cancer mortality, all-cause mortality in breast cancer patients, 38% in cancer-specific mortality, and similar associations in all of the cancers. Most of the evidence we thought was moderate, although it was limited for prostate cancer and all-cause mortality. Now, one thing, if you recall the previous slide where I talked about the evidence for incidence, it was about 15 to 20% reduction. But look at this here, you're seeing 37 to 48%. And part of me thinks that's fake news. And the reason I think that is because there still could be a residual effect of treatment or persistence of disease. So you've spent any time with cancer patients that are going through treatments or that are going through, or their disease is disseminated, even if they don't have a formal diagnosis of recurrence, they still could have extreme fatigue and really not feel like they're able to exercise. So without stronger evidence that treatment and extent of disease could be controlled for, we really felt like this evidence was moderate for these associations. We also saw insufficient evidence to determine if physical activity was associated with recurrence, and part of that is because recurrence is very difficult to quantify across different types of studies. We did see moderate evidence for dose-response relationship for breast and colorectal cancers, but only limited for prostate cancer. So I'm just going to show a few slides with some data. And you don't have to read what all these different things say. I just want you to look at the patterns. So this is from an excellent pooled analysis. It's from the NCI Cancer Consortium, where they took 12 cohorts and added together their data, and they were able to come up with estimates for many types of cancers. They still had the problem for these different studies collected data in different ways, physical activity in different ways, and assigned, and for each individual studies, therefore had different ranges of physical activity. So here we're also looking at high versus low, but in this case it's the top 10 percentile versus the bottom 10 percentile, but that varied by study. But it still gives you a good picture. And you can just see how many studies are to the left of that line. If it was that straight line, if it was on the line, that would mean no effect. If it's to the right of the line, it means exercise increases risk if it's at high level. If it's to the left of the line, it decreases risk. So you see quite a few cancers have decreased risk. And melanoma is one where we considered it for the physical activity guidelines, but we didn't think we could account for the potential confounding effect of sun exposure. So we did not address that in our guidelines. But this pooled analysis was able to look at some subgroups which we thought were very important. One is obesity, body mass index. So looking at individuals who are normal weight or who have high levels of body mass index in the overweight or obese categories. And you see the same, for individual cancers, there was some variability by body mass index, meaning sometimes the obese individuals did not get the same effect as a normal weight did, but many times you still see benefit for many cancers. By sex, you also see benefit, may not be statistically significant for both sexes, but you still see the same kind of trend overall, that both sexes are getting benefit from physical activity in terms of reducing risk of at least some cancers. And then one other piece of evidence that was really missing in what we reviewed in our meta-analyses for the physical activity guidelines was what's happening in different race ethnicities. Some of the studies that we reviewed in the guidelines committee were based in Asia, so we had some information about Asian populations, and they tended to have similar effects of exercise as did Caucasian populations. But we had very little information on information in Blacks or Latina populations. And the pooled analysis was able to look at 4 cancers in Blacks and whites. And they did see the same kind of trend. For these 4 cancers, the more common cancers, breast, colon, and they did see similar associations. So even if it wasn't statistically significant for all of them, for Blacks, it was the same trend. So in summary, the physical activity guidelines group thought that high levels of activity reduce risk for several cancers with strong evidence, that there's moderate evidence that increased sedentary behaviors increase risk for some cancers, but that there's moderate to limited evidence that high levels of physical activity reduce all-cause and cause-specific mortality in survivors of these 3 cancers, breast, colorectal, and prostate cancers. There was insufficient evidence for several things about exercise and cancer. We don't know the exact doses to produce an exact effect. We don't know much about less common cancers. There are many cancer subtypes that we can't give information about. We don't know about varying age groups. Most of the cohort studies dealt with people in their middle to older years, not in the very old, and certainly not in the very young. And one of the more concerning areas of cancer epidemiology and incidence is that the cancer incidence for some types is going up in young adults. Can exercise in the young adulthood prevent those cancers or help prevent? We don't know. We don't know much about race and ethnic minorities. We don't know about sex differences for some cancers. Individuals who are at high risk, these are people that are highly motivated to make lifestyle changes, people with something like the BRCA gene or other types of genetic predispositions. We don't know whether exercise overall can reduce their risk. And we don't know anything about people from varying socioeconomic classes. So what mechanisms could be explaining this? If you see an association, is it just by chance? Is it due to something else in exercisers' lifestyle that's causing an association? Or can there be real biological effects? And ACSM is really strong in looking at the biology of exercise. And so in physical activity and cancer, we're trying to do that as well. So I have a very simple diagram of things that we've thought about and tested, and some other people have tested for other diseases. That physical activity could perhaps lower inflammation. It may lower circulating estrogens. It may affect angiogenesis. I put a question mark there because sometimes it could improve it. It may alter androgens, decrease insulin and glucose, could decrease oxidative stress perhaps, affect adipokines, and those could affect cancer risk and cancer survival. I'm going to show you some data for 4 cancers, just some examples of some of those biomarkers I just mentioned, how they might be related to cancer. So this is a pooled analysis that was done in 2002, where 9 cohort studies had postmenopausal women enrolled in the study. They collected blood long before a woman developed any type of cancer, and then later combined data to look to see what's the association between estrogen levels in the blood and risk of cancer. And they divided those women into 5 categories. And you don't have to look at what all of the different sex hormones are. They're estrogens and androgens. But just look at the picture over here, that for each one of these types of sex hormones, as the level goes up, the risk of breast cancer went up. The only exception is the binding protein that makes the hormone less active. So that's one example. C-reactive protein, a measure of inflammation, has been associated with risk of breast cancer. This is in a meta-analysis also. Just the bottom line is that for each doubling of CRP level, there's a risk increases for breast cancer by about 6 or 7%. Insulin, as you know, is so important in risk of cardiovascular disease and diabetes. Well, it turns out it's also relevant for cancer, and insulin may fuel growth of tumor cells. So this is an example of C-peptide, which is part of the insulin molecule, was associated in a meta-analysis of cohort studies looking at high versus low levels of C-peptide, and you can see the same sort of thing. Things to the right of the line being positive, and a summary relative risk of about 1.37, which means those who had high levels had 37% higher risk of developing colorectal cancers than those that had low levels. And then one final example, adiponectin is an adipokine, which tends to be inversely related to obesity. And we found that adiponectin in a meta-analysis was associated with, if it was higher levels, was associated with decreased risk of pancreatic cancer. So these are just examples of things that exercise could move and that perhaps are related to risk of cancer. So then one question is, does exercise affect cancer biomarkers? And there has been a series of randomized clinical trials to answer these questions, and some of them we've done in Seattle. I'll highlight some findings we had, but the first one I'm going to show you again is another meta-analysis, and again, don't look at the individual line, just look at the picture. Each one of these little dots on the right represents the results of a study. So I don't know how many of you do clinical trials, but if you do ones that are large enough, and 2 of those are from my studies, one had 173 women and one had 439. So it takes about 5 years to do those studies and then more time to collate the results and publish them. And these are several million-dollar studies. So all of that work, and it's boiled down into a little green dot on a picture. But this is research, and this is important to do, to summarize and put the data together. But somebody did do a meta-analysis of the effect of exercise on circulating estrogens. And some of these papers are earlier, and some are in premenopausal women, and some are in postmenopausal women. But you definitely see a significant trend. Again, the summary to the left of the line, meaning reduced estrogen levels significantly with exercise in a clinical trial. We found these saw greater effects for lower duration. Perhaps the exercise waned a little bit towards the end of the study. More effect in postmenopausal than premenopausal. More in overweight versus normal weight or obese individuals. More with resistance exercise, and more with hard versus light exercise. 3 to 5 hours a week was optimal, and exercise in group sessions, perhaps that just helped with adherence. And significant weight loss was definitely associated with greater effect on estrogens. So in Seattle, we've done 3 large-scale clinical trials. All were 12-month duration. 2 were focused on postmenopausal women and breast cancer biomarkers. And 1 was focused on men and women looking at colon cancer biomarkers. And the ones in postmenopausal women were all focused on women who were overweight or obese. And we looked primarily at sex hormone endpoints. In the study in the middle, the appeal trial, we looked at cancer-related biomarkers in men and women. So what did we find? In the 2 studies that were focused in postmenopausal women, overall, the women met 80% of their goal, which was 225 minutes a week of moderate, vigorous exercise. On average, the VO2 went up, so that's what you'd expect, an average, even though not everybody does. They decreased their fat mass and intra-abdominal fat area significantly. But we did see some variability in whether they lost estrogen. So in general, the estrogens decreased with exercise by 12 to 20% if the women lost weight or fat mass. Similar to other trials, we found that leptin, insulin, and insulin resistance decreased. C-reactive protein, the inflammation marker, reduced if fat mass was reduced. Oxidative stress reduced if VO2 max went up. So a lot of subgroup analyses here. Some suggestion of angiogenesis decreasing. Prolactin, which is another risk factor for breast cancer, decreased. But no effect on several other biomarkers that we've looked at, including growth factors and telomere length and DNA damage repair. So some picture is telling me overall that exercise may have benefit. It may be working through something like a decrease in fat mass, but it also may see an effect if you get people to exercise at very high levels. Then the results in the colon cancer trial, we gave people a higher goal there. We gave them 360 minutes a week of moderate vigorous activity. So it was an hour a day, 6 days a week. And the men outperformed the women in terms of percent. They reached 107% of their expected goal, and the women reached 82%. And my staff wanted me to only do studies in men after that. Both increased VO2 max on average, and they both lost a small amount of weight. That's all you're going to see with weight loss in general with exercise only. We then looked at some markers of colon cancer risk. So this is the only slide I have that where I'm going to bore you with looking at a colon. But this is the inside of a colon. Colons have crypts, little crypts through the whole thing, and they have cells lining the crypt. And this picture on the left is a healthy-looking crypt where all the proliferation, that's a marker of proliferation, Ki67. It's all at the base. If you get proliferation further up, that's increasing risk for colon cancer. So we did see that in men, you did see a decrease in that marker of proliferation, Ki67, that was dose-dependent and statistically significant, so no effect in women. And then we saw some variable effect on apoptosis, which is cell death. No effect on several other markers, however. So we have some ongoing research. We're looking at other biomarkers. We're looking at long-term effects. We have a study that is extending one of our trials for another 18 months. We're looking at some more molecular markers like gene expression, microRNA, colon DNA methylation, and colon gene expression. And then we're also looking at weight loss patterns in relation to these biomarkers. With some research needs, I think, in cancer prevention, our epidemiology studies could be better if we could have objective measures of physical activity. Looking at various types of exercise and different doses, having better handle on what's happening in various subgroups, like by age, race, ethnicity, sex, and socioeconomic status. And certainly we need to look at some of the less common cancers. We need randomized clinical trials to study long-term effects if possible, with different types of activities, and also looking at reductions in sedentary behavior. It would be wonderful to look at trials in acute in acute effects of exercise. Can you see effects and change in that day's level of cancer-related biomarkers, similar to what you can see with blood pressure or insulin? And then looking at additional populations, diverse age groups, race, ethnic groups, and persons at high risk for cancer. In terms of cancer survivorship, this is critical to have randomized clinical trial data because of this potential effect of treatment and dissemination of disease. The randomized trial would really help with eliminating that type of bias. Looking at different types and doses of physical activity, looking at reductions in sedentary behavior. Looking at acute effects would be useful as well. And as with cancer prevention, we need to know about certain subgroups by race, ethnicity, and SES. In terms of cohort studies, this is a patient cohort studies where you ask somebody, when you identify somebody with a cancer, ask them what exercise they're doing and follow them over time for outcomes. And we only have that data very well described for a limited number of cancers. So having more information on cancers, including subtypes, would be useful. Knowing complete treatment and disease status. again, and looking at different types of exercise and having standardized and objective measures of exercise would be useful. There are 2 randomized trials ongoing in cancer survivors, none in breast cancer, but there are 2, one in colon cancer and one in prostate cancer, and these are multi-center. One is in prostate cancer. We're one of the centers, and it's a 12-month exercise program versus control, and they will follow people to look at survival. So large scale, 866 men. A challenge trial is looking at the effect of a 3-year structured exercise program in patients with colorectal cancer. And there'll be over 960 patients in that with the primary endpoint of disease-free survival. So in terms of implementation for cancer prevention, we'll have the 2018 physical activity guidelines. We'll see what they say. The American Cancer Society has guidelines for lifestyle for cancer prevention, as well as the World Cancer Research Fund and American Institute for Cancer Research. These guidelines are general, but they include physical activity, specific physical activity guidelines. Primary care involvement could help by giving patients a little bit of an extra push. Third-party payer doesn't exist now for physical activity, but it would be nice if it could extended into that area. And we need prevention at all ages. I told you about cancer occurring more often in younger people, but anyway, lifestyle activity is going to be more prominent if it could be started at younger ages. So if you could start this little tiny video. I just wanted to show that. It's a family fun run. This little guy's my grandson, so I wanted an excuse to show my grandson. That was last year when he was 4. In terms of cancer survivors, there were a few more guidelines. American College of Sports Medicine is putting together a white paper under Katie Schmitz's guidelines, and they have previously done this, and they're going to be continuing to do it. It's so important for the things that we did not touch on today or in the guidelines committee, these are the U.S. committee, which is quality of life and adverse effects of treatment or of the cancer. So exercise can have an important role there. The American Cancer Society and then the World Cancer Research Fund, American Institute for Cancer Research also have guidelines available. ACSM has a cancer certification for trainers. I highly recommend it. If you try to work with a cancer patient survivor and you don't understand the thing they're going through, it's going to be a little frustrating for both you and the patient. So getting whatever kind of training you can get, if you're somebody that's training or you're doing providing clinical support for cancer survivors, the more training you can get, the better. The YMCA has a program. Many hospitals and clinics have programs as well. There's some patient-based programs. I'm giving an example in the picture there is Team Survivor Northwest. These are a group of women that get together and exercise together. Oncologist involvement for cancer survivors is really critical because many people will not do anything unless their doctor says, do this, or it's okay to do this. So oncologists, in some cases the surgeon too, but it's really important. And then third-party payer would be really nice and helpful in the future. So conclusions, in terms of cancer prevention, we've seen that high levels of physical activity are associated with reduced risk. Maybe sedentary behaviors associated with increased risk. We've seen that physical activity interventions that in the setting of human experimental studies support biological effects of physical activity relevant to cancer. Some suggestions, some physical activity results may depend on adiposity, on fat mass or change in fat mass. There's some evidence of dose-response effects, but we have to take a leap of faith. So you're going from observational studies that look at epidemiologic studies that could be subject to confounding effects of other variables, and you're adding to that the human experimental studies that are small. We do not have large-scale clinical trials of exercise and prevention of cancer. And another picture of grandkids. I had to get another picture in. And then for cancer survivors, this is a fellow who's riding in our Obliteride. Our cancer center has a fundraiser where they do bicycle racing. For cancer survivors, we see insufficient physical activity is associated with decreased survival. There are some ongoing trials to look at the effect of cancer, in cancer patients, the effect of exercise on hard endpoints, meaning survival or disease-free survival. And that the guidelines are available, but they're based on limited information. So it's really important to get more clinical trial data, and then to have the people like ACSM putting their focus and see what's available, what's the best evidence, what's the best practice that we can have for these patients. There are too many people involved in all of these studies to give thanks to everybody, so I put them in quantities. So there's the US government, various research organizations, funding organizations, study participants. Millions of people have been in these studies, various staff and interns, fellows and students, physical activity guidelines members, and consultants and staff. And then, since we use meta-analyses and many other source documents, the authors of those have been extremely helpful. And we appreciate also our many colleagues. So in the next few days, there's going to be other talks by physical activity guidelines members. So please go to them, and you can learn even more about the work of the guidelines and various. They looked at many different disease endpoints and health benefits of exercise. And I'll finish with this slide. This is Fred Hutchinson Cancer Research Center in Seattle. That's Mount Rainier behind it. And I like to think of it as an example of a mountain that our cancer patients have to go over, and that ACSM can help them get up that mountain, but also our general population to try to reduce the impact of cancer in our society. Sometimes it's like a mountain, but with help, we can get up there. Thank you.
So we asked the Wolffe Lecturer to do two things for us. One is to present cutting-edge research, which you did. But more importantly, we asked the Wolffe Lecturer to challenge us in new and exciting ways, and you more than exceeded our expectations. So thank you so much for being here. And thanks to Katie Schmitz for inviting you. On behalf of the American College of Sports Medicine, we'd like to present to you this small token of our appreciation. And thank you all for being here this morning. Don't forget, in front of Hall B, in the floor above us, is Elevate ACSM. Don't forget, hashtag Elevate ACSM. If you have any questions about the Capitol campaign, see one of our cabinet members. And please go to the exhibit hall and see each one of our exhibitors. It's extremely important to get their support. Thank you. Have a great meeting.